Thank you very much. I'm going to start with a case that we had during my last hospital rotation in March. This is a woman that I saw with Mike Lucky, one of our fellows. And the reason we were consulted was, where's the pointer? As you can see, was this finding on the CAT scans. This is a CAT scan of the abdomen, and this patient had this periaortic mass, and they figured out this time to call rheumatology. This woman presented initially, she was a 50-year-old woman, she was a smoker, and she presented with abdominal pain, nausea, and vomiting. And when they did the usual blood work, she had some anemia, creatinine was normal, and she had an elevation in C-reactive protein of 3.2. The CT abdomen was read as this concentric, irregular, retroperitoneal soft tissue thickening surrounding the abdominal aorta below the origin of the SMA. And, other than that, she had, there was evidence on the CAT scan that there was some obstruction causing hydronephrosis on the right side, and also the CAT scan described that this mass was compressing the left renal vein. And so this woman underwent a CT-guided biopsy, and this showed basically that she had a fibroinflammatory infiltrate. There was any evidence of malignancy on pathology, so they called us to treat her. So this is a classic presentation for a patient with retroperitoneal fibrosis, and certainly I think a lot of people here have a lot of questions how we are certain that this is a benign condition. How do we decide, how do we image these people, how do we interpret the pathology reports, and how do we choose our therapy? And I'm not going to give you a lot of answers about any of that you can use. So this retroperitoneal fibrosis has many names, and in all the literature, it's also called Albarran-Ormond-Gerota syndrome. And the first one who actually described the patient was Joaquin Albarran in 1905, and he wrote a paper. He presented to the French Association of Urology a paper where he talked about renal retention by periuretritis, and the therapy that they used was to release the ureter. And this is Dimitri Gerota, and the reason I put him here is because he's Romanian like me. And he actually, but they both studied in France, and they studied with Félix Gouillon. And this is just to show how powerful the French School of Medicine was and how much it influenced the initial developments in the early 20th century in medicine. And he also described the structural, supporting structures of the kidney. And in parts of Europe, this is also known as Albarran-Gerota syndrome. Anecdotally, he also taught Constantin Brâncuși, who is a famous sculptor, he taught him anatomy. In 1948, the one who actually gave this name of retroperitoneal fibrosis was John Kelso Ormond, and he was actually a urologist who worked at Henry Ford Hospital in Michigan, and he described two cases that were both young men in their 40s, and these people presented with bilateral ureteral obstruction. The first case that he described was a man that actually died, and the reason he died, he had bilateral hydronephrosis, developed obstructive renal insufficiency, and not only that, so he didn't only die because of renal failure, but he also had significant pyelonephritis secondary to the renal obstruction. And when they did the autopsy, actually he described that both kidneys were destroyed by infection. And the second patient, they managed to save because he underwent a surgical procedure, and they were able to do ureterolysis. So this is the paper, and he starts by saying that the following two cases I deem worthy of presentation to you because not only they are unique in my experience, but I have so far been unable to find any similar cases on literature. So obviously wasn't aware of the Albarran paper. This is what he really described. Both of these patients had actually a dense grayish fibrous retroperitoneal mass, and this mass surrounded the aorta, and it compressed but did not invade the ureter. So that's an important observation. Actually, the ureters are patent. Even when these people develop hydronephrosis, they actually are just compressed. And also compressed the IVC. Further down the line, Mitchinson in 1970 published 40 cases of retroperitoneal fibrosis, and I took these pictures from him. And this is an illustration of this whitish mass that surrounds the lower part of the aorta. And you can see here the right and the left ureter. The right ureter is dissected, and you can see how they are pulled together towards this mass. These are cross sections of the aorta, and you see this kind of whitish fibrotic mass that surrounds it. And here you see how it encases also the inferior vena cava. In terms of going further with the terminology, besides using the name retroperitoneal fibrosis, the other term we use, and it's promoted currently, is the term of chronic periaortitis. And the reason for that is because, as you can see in this tissue biopsy in this section of the aorta, you can see that a lot of this process involves the outer layers of the aorta, especially the adventitia, which is very much thickened. And from this perspective, you either call it chronic periaortitis or retroperitoneal fibrosis, either one. They can come in two flavors, with a normal size aorta or a dilated aorta. Now, I don't want to create too much confusion, but this situation here of chronic periaortitis or retroperitoneal fibrosis with dilated aorta is also called inflammatory aortic aneurysm. How common is this condition? It's about as common as Church-Strauss syndrome, 1.38 per 100,000 people. The incidence is 1 per million, tends to affect people in their mid and late 50s. Definitely, and there is recurrent observation in multiple cohorts that this is a disease that affects predominantly men. About 2/3 are generally reported to be men. How does it present? Well, it's a chronic inflammatory condition, so you can think very simple, how does it present? A lot of people, when they develop it early on, they have a lot of systemic features: fever, weight loss, decreased appetite, and then there are local symptoms. It presents with abdominal pain, flank pain, or back pain. And the third category of symptoms that you're going to see are symptoms related to the effects of the mass in the area. So people can present with hydronephrosis, and if that occurs fairly acutely, they can have abdominal pain, nausea, vomiting, secondary to the distension of the renal capsule. A lot of these people can come to the hospital because they have pyelonephritis, which is secondary to the obstruction. So they can come with fever, nausea, vomiting, and positive urine culture, and further testing just shows that there's a reason for that due to obstruction. Also, other presentation, if it encases the inferior vena cava, what you can see is lower extremity edema. You can see scrotal edema, and in rare cases it can also compress the gastrointestinal tract, so the GI symptoms can be related to that. I tried to summarize. I had a very nice, long, and unreadable table that basically gave you all these numbers. So I summarized it and I put the percentages of the frequency of symptoms. SED rate and CRP are usually, but not always, elevated. And I just put this part here because we call it chronic periaortitis. So the vast majority of patients, this fibrotic mass occurs around the aorta. But in all these series that I reviewed, there are a few patients who actually had this mass that was deemed to be retroperitoneal fibrosis in other locations, just periurethral or periiliac, retrovesical, or around the tail of the pancreas. So in terms how extensive is this mass and where it's exactly localized? So this is a summary of the data from Mitchinson, who reviewed 40 cases of retroperitoneal fibrosis. It's usually below the renal arteries, the distal aorta and iliacs, and but it can extend and it can involve the entire aorta up to the chest and to the root of the aorta. So there are cases that can have diffuse involvement. Doesn't go below, usually below the pelvic rim. Lateral extension is usually it pulls because it's a fibrotic process. It doesn't pushes the ureters away, it just pulls them together. And there is some anterior extension into the small bowel mesentery and with possible displacement of the duodenum. This gastrointestinal involvement is more prominent in people with inflammatory aortic aneurysm, and it can cause significant problems for surgery when these people go for aortic repair. How does it look histologically? Well, you know, these two pictures, sorry, they're black and white. They come from Mitchinson's 1970 paper. He presented 2 patients that had tissue biopsy at the onset of disease and later on. And this is a very important observation, and I think has some clinical and treatment consequences, because as you see initially when early on, there's a lot of inflammation. You have this dense inflammatory infiltrate and fibrosis, and then these cases became so-called old-looking, acellular. So you can still have in some patients who a mass, but it's not inflammatory, so chances that you're going to be able to treat this with any kind of immunosuppression probably are very low. When they actually describe what's happening in the aorta, they noticed that intima could show marked fibrosis, and then there was this evidence of an inflammatory infiltrate in the media and adventitia and extensive fibrosis. The vasa vasorum, you know, vasa vasorum are interesting, and we learned in the vasculitis meeting that in large vessel vasculitis, these are the gatekeepers or the non-gatekeepers of inflammation in the aorta. And even in retroperitoneal fibrosis too, patients with, there is evidence of infiltration around these vessels, and some actually show frank vasculitis. What are the cellular players? On the inflammatory side, we usually see small lymphocytes, T and B cells. We have macrophages, plasma cells, eosinophils. Take-home message: if there's a lot of neutrophils, look for infection. The fibrous component contains fibroblast and myofibroblast and extracellular collagen. The inflammatory infiltrate, as it's illustrated here by a nice pathology review by Corradi, shows that this inflammatory infiltrate can be more localized follicular, or it can be diffuse. In terms of pathogenesis, you know, there are a lot of theories, and a lot of the older papers reported people developing retroperitoneal fibrosis taking certain drugs like nitrofurantoin or migraine medications, also associated bromkriptine, beta blockers, and other common drugs. One important association, and I think there's weight to this, but it does not apply in all the cases, is the association with advanced atherosclerosis of the aorta. And the theory is that oxidized LDL is taken up by macrophages and triggers an inflammatory infiltrate, an inflammatory reaction. There's also probably a mechanical component that, in my mind, has some bearing too. It is believed that when people develop aortic aneurysm, the post-stress and the mechanical pressure can trigger this fibrotic reparatory response. There are some people who believe that you can have small breaks in the vessel of the aorta, and this extravasated blood triggers an inflammatory reaction. There is some small evidence about shift towards a Th2 response. And, you know, besides the primary cases of inflammatory aortic aneurysm and retroperitoneal fibrosis, this has been described as secondary in a lot of situations. In malignancies, some of these fibrotic, some of these cases with fibrosis around the aorta can be actually truly malignancies that either generate, that can generate a desmoplastic reaction, and in some cases it's thought that it's a paraneoplastic reaction. We should not forget that infections from the local organs can spread there, so this is something always we need to keep in mind. Going back to this theory of atherosclerosis, I said there is evidence for that, and actually Mitchinson was very impressed by these findings that in many patients with advanced atherosclerosis, this is the lumen of the aorta, and you see this huge plaque that actually extended in the media and in the adventitia. So there is some evidence for that all the retroperitoneal process is a reaction to this everybody wants to hear about the IgG4, right? Every time we have a case that we don't know what the diagnosis is, we're very excited and we think, oh, maybe it's IgG4 disease. Well, what is IgG4 disease? Hamano in 2001, looking at patients with autoimmune sclerosing pancreatitis, they determined that, they noticed that their serum levels of IgG4 were elevated. Further researchers took that further, and they actually thought maybe if it's elevated in the serum, it's got to be elevated in the tissue. So they actually did immunohistochemistry in people with autoimmune sclerosing pancreatitis, and they found that some of these patients had elevated levels of plasma cells that were IgG4 positive. Not only that, but some of these people had similar infiltration in other organs, including retroperitoneal tissue. If you look at the whole literature, I didn't put it here. If you look at all the data of that's out there regarding IgG4-related sclerosing pancreatitis, about 10% of those studies report associated retroperitoneal fibrosis. After all these findings, finally people came up with a consensus that actually IgG, and coined this term IgG4-related systemic disease, which is what? Can involve various organs. All of them are listed here, from lacrimal glands, parotid glands, lungs, retroperitoneum, pancreas, so on and so forth, thyroid. It tends to affect men who are middle-aged or elderly, responds greatly to steroids, and for diagnosis, you have IgG plasma cells in tissue, and you IgG4, and you also have an elevated level of IgG4 in the serum. And histologically wise, it's a lymphoplasmacytic infiltration with irregular fibrosis and obliterative phlebitis. Now, I tried to summarize as much as I could the data with regards to IgG4 and retroperitoneal fibrosis and inflammatory aneurysm. So what basically I found that if you look at retroperitoneal fibrosis, of all the cohorts that I listed here, about the reported frequency of IgG4 positive cases is between 10 to 59%. Now, how do we know they are, how do they consider they were positive? There are two ways to say they were positive. One, you look at the IgG4 over IgG ratio in plasma cells in the tissue. And in retroperitoneal fibrosis, these were considered more than 30 or 40. Or you look at the IgG4 positive plasma cells per high power field. And the only one case reported that when I looked at the cohorts on retroperitoneal fibrosis, and the ratio was 13 versus 1. When you look at the inflammatory aortic aneurysm, there are studies that looked at inflammatory thoracic aneurysm and others that looked at inflammatory abdominal aneurysm. And the prevalence of IgG4 was 4 to 12% in thoracic and 40 to 57%. But what's interesting, and when you talk about IgG4, what did they consider? IgG4 plasma cells are seen also in atherosclerotic aortic aneurysm. They're not like you see this in the tissue and it's a slam dunk. This is definitely an IgG4 related manifestation. Actually, inflammatory aortic atherosclerotic aortic aneurysm had IgG4, but the cutoff, what they found in the aortic aneurysm was if they were more than 50% per high power field, that was definitely seen only in cases of inflammatory aortic aneurysm, not in atherosclerotic ones. There are a lot of questions, and I'm sure I'm not going to be able to answer them regarding IgG4. What is the clinical significance of this finding? Are these the people who behave differently in terms of symptoms? Are these people who are going to have a different prognosis? You know, the other, and maybe will benefit from different kind of therapies. There are several observations that I want to make. John Stone published 2 cases of infectious aortic aortitis, and this bacterial infections of the aorta, and both had very high levels of IgG4 plasma cells in the wall. The other observation that I tried to make, we don't really know the true prevalence because there is evidence to show that these IgG4 plasma cells disappear with steroids. So this is up in the air. And the other thing about IgG4 is that IgG4 is not necessarily a pathogenic antigen. Antibody. This IgG4, the presence of IgG4 in tissue plasma cells that are IgG4 positive may actually show an attempt of the body to contain the inflammation. And that is because if you look at IgG4 antibodies, they cannot fix complement. They are not able to form very good immune complexes, and they also do not fix very well, do not adhere very well to Fc receptors. So they may be, the presence of these IgG4 plasma cells in tissue may only be an indirect marker of a way in which the immune system tries to contain a response to a chronic inflammatory process. This is the histology that has been associated with IgG4 positive cases. So you can see that basically this is a section on the aorta that shows a very dense lymphoplasmacytic aggregates in media and adventitia. Here we see a lot of plasma cells and some eosinophils. This is an evidence of what has been associated with it, obliterative phlebitis. This is the inflammatory cells infiltrate that go along the nerve fibers, and this is the staining, immunohistochemistry staining for IgG4. A few words about the role of imaging in retroperitoneal fibrosis. So obviously we would like to have the imaging, we would like to tell us what the extent of the disease is, what is the stage of activity, and help us differentiate from benign idiopathic cases from malignancies. And I didn't find any literature to tell us if doing a CT versus an MRI is a better option. I think the choice is influenced by very, very down-to-earth reasons, including if the patient can or cannot take contrast. Overall, this is just a table that I've summarized the utility of MRI to differentiate it between malignant and idiopathic retroperitoneal fibrosis. And it's not a surprise that what it suggests is that people who had lobulation or nodularity versus the plaque-like, those who were where the mass was higher in the retroperitoneum, or where there was more fibrosis behind the aorta, pushing the aorta forward, or the mass was pushing the ureters away, not pulling them towards the aorta, was more suggestive for malignant cause than than in the absence of these findings. You know, we would love to have PET for these patients, and we would love to be able to do PET CTs that can tell us how extensive the process is, how active it is, and then do it 3 months down the line after we treated the patient and everything's quiet and silent, and we know that we did a really good job. The problem with PET is that there is a lot of lack of standardization, and if you look at the small case series that looked at this, patients can have improvement in PET without regression in mass. and we don't really know what that actually means. This is also plagued by the fact we don't really have clear definitions of remission or partial remission. But this is a picture of a patient who had a positive PET, and it shows how this lights up in the abdomen, but also in the thoracic area. This is another patient that was treated with tamoxifen before and after. You can see the mass here. You can see the hydronephrosis on the left, and then resolution with treatment. And this is the CT imaging, which shows the mass that has decreased after treatment. A few words about treatment. We use a lot of drugs, but there are no randomized, double-blind, placebo-controlled trials. So I could stop right here. We use also surgical methods, and many of these patients end up having ureteral stents. In some cases, ureterolysis solves the problem by diverting the ureter from the compressive mass. And there also, I'm going to talk briefly about the utility and the impact of surgery for aortic aneurysm in these patients. The medical treatment, glucocorticoids, colchicine, tamoxifen, DMARDs, and biologics. Sounds impressive, but it's actually very thin. If you look at the surgical aspect of the treatment of inflammatory aortic aneurysm, basically you can treat this aneurysm in two ways. You can do the open repair, or you can put an endovascular stent. And there's a lot of data that suggested that patients who undergo surgery for their inflammatory aortic aneurysm, actually the inflammatory mass around the aorta can regress. So this is really good. So you just send them for surgery, the mass regresses, don't need to give them steroids. So what is the evidence for that? Well, there are several analyses of studies, and I only choose to put one for the sake of time. This is from 2009, and looked at 56 studies that had a 1-year follow-up by CT. And what they really found, these are patients who went on, all had inflammatory abdominal aortic aneurysm. Some went for open repair and some for endovascular grafting. And what we really see here is that the periaortic inflammatory process regressed in 73% with open repair and 65% of those who underwent a graft. But when you look at the hydronephrosis, there was a difference between those with open repair and those who had the graft, in the sense that there was a much higher chance to have a regression of the hydronephrosis if you underwent open repair. Open repair sounds great though, but it comes down with much higher mortality, both at 30 days and 1 year. And in many of these cases, as I said before, it can be surgically difficult because of the adhesions between the retroperitoneal mass and the surrounding structures, including the duodenum. And when they broke down the cases that improved with just an endovascular repair, they actually found out that when they looked at the use of steroids, those who actually improved in hydronephrosis were on steroids. There were much more patients on steroids than those who just had the repair without steroids. So the role of endovascular stents without adjuvant treatment is not really clear. In terms of medical treatment, well, how do we treat these people? We give them steroids and maybe another DMARD. That's kind of the idea. And there are no really good studies to tell you exactly what you should do. I try to summarize the ones with the largest number of patients. So you can see 17 patients, 26, 19. This is the largest study that I found. It comes from Mayo Clinic. This was their retroperitoneal fibrosis cohort. And 151 patients had a median follow-up of 1 year. And they presented their treatment data. Nothing here was randomized or standardized, but these people, they had 63 people who were receiving glucocorticoids, most of the time with another drug, either tamoxifen or some other sort of DMARD. And what they found is that 9% of these patients had a complete resolution. 54%, so about half, with this kind of treatment improved on imaging. 34 were stable, 3 progressed, 12% relapsed, 7.3 died, and in 63% of patients, the stents were removed. They stopped the steroids in half, and at 1 year, 3/4 of patients were still taking some medications for retroperitoneal fibrosis. I know you want to hear about tamoxifen. Tamoxifen is interesting because there are several studies that looked at it without glucocorticoids. So in a way, offers us a different kind of approach than the usual approach to chronic autoimmune inflammatory diseases. But again, the literature is poor, and while there are case series, as you see, 26 patients, 19 patients, 55 patients that report improvement with tamoxifen, it's not really clear that that kind of improvement they describe is not very standardized. So it's not like we had real clear guidelines what improvement meant. Of course, they described it in their studies. For instance, this study on 26 patients, they 58% had success in clinical, lab, and radiological improvement. Van Bommel had a more kind of consistent way of looking at the response to tamoxifen, and they initially presented 19 patients, and then they presented their 55 patients that they treated with tamoxifen, and the dose they used was 40 milligrams per day, no steroids. And in their 55 patients, what they reported as treatment success was resolution in symptoms. The mass should have been stable or regress, and the hydronephrosis should have resolved. So that's what they call treatment success. So in their patients, 65% had an improvement, achieved treatment success. But if you really look at hydronephrosis, only 17% of cases who had initial hydronephrosis responded. So what they said, you know, this is a good option. It takes a while to see improvement. They notice changes, more changes at 8 months than 4 months, but maybe having hydronephrosis at the beginning may be a predictor for not having such a good response to tamoxifen. And the only randomized study with tamoxifen was done by Valio, and this is a kind of a remission maintenance kind of study. They took 40 patients who had retroperitoneal fibrosis, new patients. They gave them prednisone until they went into remission, 1 milligram per kilogram. So 36 patients achieved remission, and then they randomized them. 18 were continued prednisone, and 18 only got tamoxifen. And they were treated for 8 months, and then the treatment was stopped. So during this remission maintenance treatment, only 5% of patients on prednisone relapsed, but 33% of patients on tamoxifen. So it's very difficult to say and draw any conclusions from this. Maybe tamoxifen would be an option in people without other risk factors, with not severe disease and contraindications for steroids. Biologics in retroperitoneal fibrosis, this is my last slide. You can count the cases. So 3 with rituximab, 1 with infliximab, and 1 with tocilizumab. So the field is wide open. There is some data that comes from Dr. Stone that using rituximab for IgG4-related disease may be an effective way to treat this patient. The patients, 3 of their 10 cases had an inflammatory aortic aneurysm, and all the patients that were treated with rituximab had a good response. There is one case of tocilizumab in a patient who had an inflammatory thoracic aneurysm and retroperitoneal fibrosis. This comes from the Italian literature, but it was presented only in an abstract. So there are a lot of unmet needs in retroperitoneal fibrosis, which start with understanding better the pathophysiology of disease, having better criteria of what we define remission, and developing randomized controlled trials to try to answer what is the best way to manage these patients. So thank you very much, and if you have any questions.